La meningitis bacteriana no es una infección común. Es una carrera contrarreloj donde cada minuto cuenta como una urgencia médica crítica. Médicamente, se define como una inflamación aguda en el espacio subaracnoideo que afecta directamente al cerebro y sus membranas protectoras. Pero, ¿cómo logra un enemigo microscópico burlar los sistemas de seguridad más estrictos de nuestro organismo para sitiar el órgano más protegido del cuerpo? La respuesta está en su asombrosa estrategia de infiltración. Para alcanzar el sistema nervioso, los patógenos deben fracturar barreras biológicas críticas. Estos patógenos, como el neumococo, deben cruzar lo que la medicina conoce como las 3 brechas. Vamos a analizar este asalto celular detalladamente. La primera brecha es la colonización de la nasofaringe. Aquí, las bacterias se adhieren y logran cruzar al torrente sanguíneo a través de las uniones celulares. La segunda brecha ocurre en la sangre. Usando una cápsula como escudo molecular, las bacterias evaden nuestras defensas para poder diseminarse por todo el cuerpo. Y finalmente, la tercera brecha, el cruce de la barrera hematoencefálica. Al llegar a los plexos coroideos, los patógenos obtienen acceso directo al líquido cefalorraquídeo. Una vez dentro, las bacterias se multiplicarán rápidamente. Lo paradójico es que nuestra propia inflamación defensiva causa graves daños. Esta inflamación causa a veces más daño neurológico que la propia bacteria. Por eso, en la meningitis, cada segundo es vital.
The human brain exists in a state of strict biological isolation. It relies on a network of tightly packed endothelial cells, the blood-brain barrier, to filter out foreign particles and maintain a sterile internal environment. But for approximately 2.5 per 100,000 people in the United States each year, this isolation fails. Acute bacterial meningitis can advance from a common headache to a fatal neurological event in less than 24 hours. This rapid escalation happens because of an anatomical blind spot. Unlike the blood, which is heavily patrolled by immune cells, the cerebrospinal fluid, the clear liquid cushioning the brain, contains almost no white blood cells or antibodies. Since the brain's perimeter is usually sealed, bacteria require a specific point of entry to reach this defenseless fluid. They rely on patient triggers, injuries, underlying illnesses, or environmental exposures that provide a route past the barrier. Bacterial meningitis is a disease of access. The infection only succeeds when a pre-existing vulnerability allows a pathogen to bypass the body's primary defenses. The most direct route is the physical breach, where the structural protection of the skull is either broken or worn away. Severe head trauma is a common trigger. Basilar skull fractures can tear the protective membranes, causing cerebrospinal fluid to leak into the nasal cavity. This allows bacteria to travel in the opposite direction, entering the brain through the fracture site. Medical hardware can also create a bypass. Invasive devices like neurosurgical shunts, while necessary to drain excess fluid, provide an artificial pathway that pathogens can follow directly into the central nervous system. Routine infections in the head and neck can also become triggers. If a middle ear infection or chronic sinusitis is left untreated, the bacteria can slowly erode the thin layer of bone and cross into the subarachnoid space, the fluid-filled area surrounding the brain. Localized bone damage from these infections provides a shortcut to the brain that avoids the body's systemic immune filters. The second route involves the immune blind spot, where chronic systemic conditions disable the body's early detection systems. Conditions such as diabetes, cirrhosis, and alcoholism, or the surgical removal of the spleen, impair the immune system's ability to clear bacteria from the blood before they reach the head. These illnesses weaken the complement system, a network of proteins that normally tags bacteria for destruction. This allows encapsulated bacteria, pathogens with a protective outer coating, to evade white blood cells and circulate freely. These surviving bacteria eventually reach the choroid plexus, the vascular network where cerebrospinal fluid is produced. They adhere to the epithelial cells, migrate through the vessel wall, and enter the undefended fluid surrounding the brain. Proactive management of chronic illness is essential to keeping these biological alarms active and the brain's borders closed. The third route involves lifestyle and environmental factors, where routine activities expose healthy individuals to highly specialized pathogens. Certain foods can serve as a trigger. For pregnant women, newborns, and the elderly, consuming unpasteurized soft cheeses or deli meats significantly increases the risk of a foodborne breach. The pathogen responsible is Listeria monocytogenes, which is uniquely adapted to survive the refrigeration and processing methods used for these foods. Proximity is another factor. In high-density environments like university dormitories, bacteria can colonize the throats of healthy adolescents without causing symptoms. If the host's immune system falters, these colonies can turn invasive and enter the bloodstream. Once bacteria enter the cerebrospinal fluid, they multiply exponentially. When they are eventually killed by antibiotics or the immune system, a process called lysis, they burst, releasing toxic cell wall components directly into the fluid. This release triggers an overwhelming inflammatory response. The blood vessels become leaky, causing proteins and fluid to flood the area. This leads to vasogenic edema, a severe swelling that increases intracranial pressure and restricts blood flow to the brain tissue. In the final stages of the disease, the host's own immune response becomes the primary cause of neurological damage. Because bacterial meningitis depends on these specific host vulnerabilities, the most effective strategy is to eliminate the triggers before the infection can begin. Comprehensive vaccination is the primary defense, stopping pathogens from colonizing the body even after exposure. Maintaining current immunizations for pneumococcal and Hib infections is vital. For those in close living environments, the meningococcal serogroup B vaccine is necessary to cover strains often missed by standard boosters. If preventative barriers fail, clinical intervention must be immediate. Beyond a fever and stiff neck, the appearance of a petechial rash, small purple spots on the skin, indicates that the bacteria have begun to damage the vascular system. Upon suspecting a breach, doctors administer intravenous antibiotics and dexamethasone immediately. These treatments must be started before waiting for the results of a lumbar puncture to identify the specific pathogen. Surviving meningitis requires anticipating the triggers and recognizing the early physiological alarms. Success depends on reinforcing the brain's borders before the inflammatory cascade begins.